So now let's talk about the diseases caused by Staphylococcus aureus. First one we'll talk about is one we just mentioned previously, called staphylococcal scalded skin syndrome. So what is staphylococcal scalded skin syndrome? So we're going to call it quadruple S, so we don't have to keep saying it over and over again. So it starts out as a localized erythema surrounding the mouth, as opposed to scarlet fever. Remember, scarlet fever has circumoral pallor, which means it's pale around the mouth, but the rash is in other places. But on the other hand, quadruple S has erythema starting around the mouth and then spreads diffusely throughout the body. And a key feature of this rash is that you have a positive Nikolsky sign. What is a Nikolsky sign? It means that if you push on the skin, it comes off. And that's very important to know. A positive Nikolsky sign is a very key feature of staphylococcal scalded skin syndrome. So things you can get with this syndrome are large bullae or smaller fluid-filled blisters. So the reason you get these bullae and fluid-filled blisters we talked about earlier. Remember we mentioned that you lose the desmosomes or desmoglein 1 in the stratum granulosum? When that's gone in the epidermis, you've got a lot of spaces in the epidermis, and what's going to fill in those spaces? Fluid. And that's how you get these large bullae and small blisters forming. And then after these bullae and blisters form, you get desquamation of the epithelium diffusely. So lots of desquamation here. So it starts out as a localized erythema around the mouth. You've got positive Nikolsky sign, and you also get large bullae and small fluid-filled blisters and desquamation. So the key feature is that these blisters are all sterile. There are no white cells or bacteria in these blisters. They're all caused by the toxin. So you can culture the nasopharynx or the infection source to see if this is actually Staph aureus. So don't culture the blister, culture the nasopharynx or the infection source. And the infection source could be the nasopharynx or nares or some other site of infection. So the way you treat it, since this is losing a lot of fluid, you've got a lot of fluid-filled blisters and bullae bursting, you need to replace the fluid and also give a penicillinase-resistant beta-lactam because you want to make sure that you don't have any MSSA that will not be killed by any mild penicillins. So penicillinase-resistant means that the beta-lactamase that the Staph aureus has, these oxacillin, dicloxacillin, and nafcillin have a big bulky R group which prevents the beta-lactamase from breaking down this ring. So in staphylococcal scalded skin syndrome, when you have Staph aureus being the cause, you give a penicillinase-resistant beta-lactam because all Staph aureus bacteria have beta-lactamase. And these three beta-lactams are resistant to beta-lactamase because of their big R groups like we just mentioned. And if there's a risk of MRSA, say they're in a hospital, they've been hospitalized recently, they're in a place or a community with high MRSA, you can give vancomycin to help as well. The reason why we give bacteria is so we can kill the bacteria. The reason why we give antibiotics, is that we can kill the bacteria and stop it from producing more and more toxin. So the reason for the antibiotics is to kill the bacteria and stop toxin production. Now we'll talk about the question that we had previously, Staphylococcus aureus food poisoning. So first thing is that it's due to enterotoxin production. It's not due to bacterial invasion. Just like scalded skin syndrome, the toxin is the one causing all of the problems here. So it's risky foods that you want to think about when you think of Staph aureus food poisoning. If there's a vignette with any of these foods, you should be suspicious. Salted meats, okay, beef, pork, potato salad, just like we saw on the previous page, and dairy. So dairy like the custard we saw in the sample question. So the important thing is that this toxin is heat resistant. It cannot be destroyed by reheating food. So we talked about that. Cooking the food is not going to actually kill the toxin. But what can help prevent the toxin from getting worse is refrigeration, because that will slow the toxin production and slow down bacterial growth. So the bacteria proliferate and produce toxin in warm temperatures, like room temperature. So if the food is left out, bacteria can proliferate. But if you refrigerate it, this can prevent that from happening. So symptoms include nausea, diarrhea, and vomiting. It has all three happening pretty rapidly and remitting pretty rapidly as well. So it's a rapid onset, rapid offset disease. So the treatment, you don't need to give any antibiotics for this. You just need to give supportive care, give fluids, and the symptoms should resolve on their own. Now we got some more diseases to go through. Staph aureus causes a lot of problems, so we have a lot of them to go through. Next is toxic shock syndrome. So toxic shock syndrome is a very, very dangerous condition that can cause death. So this again is caused by the toxin, the TSST1 toxin. So The Staph aureus that produce TSST1 are usually from tampon use, so in menstruating women who leave tampons in for too long, or for nasal packing. Say somebody gets punched in the nose or breaks their nose or has a major nosebleed. If the packing is left too long, Staph aureus can proliferate and toxin can be released. So this happens from tampons and also from nasal packing, and it's all caused by the TSST1. Okay, so it's starting out, you get a fever, hypotension, and diffuse macular erythematous rash, and it includes the palms and soles. So what you get with this condition is you get a major high fever, low blood pressure because you're activating so many cytokines with this superantigen, and a macular erythematous rash. You just turn red everywhere. Your entire face, body, palm, soles, all of it is red. And a nice key feature that can help you differentiate these is there's desquamation of palms and soles. Remember, in scalded skin syndrome, you get desquamation everywhere, but in toxic shock syndrome, you get desquamation only of the palms and soles. So because you're having so much hypotension, if you have hypotension, you can't get blood flow to your organs, and you get failure and shock. Shock meaning that you don't have enough blood flow to supply your organs. Diagnosis: you need to culture the source of the infection. Remember, the source is the nasal packing or the tampon, so you need to culture whatever the source of the infection was. All right, very, very important. And the treatment: remove the source of the infection and debride or drain the area. So say we have the nasal packing, we want to remove that immediately and debride and drain that area so we don't make it get worse. And you also want to give IV antibiotics so that you can kill the bacteria and prevent further toxin production. So you give clindamycin and vancomycin. Clindamycin is a very good antibiotic because it can handle MRSA and because it's good for anaerobes, and it can also inhibit toxin production. And vancomycin is the most powerful, frequently used antibiotic for MRSA. There are more powerful ones actually, but vancomycin is the most commonly used MRSA drug, especially in the IV setting. So, say you have a patient with toxic shock syndrome and they present to your emergency department. What's the next best step in management? So this is always a very classic step 2 association. The next best step in management initially would be stabilization of the hemodynamic signs by giving fluids or pressors or whatever is needed. And then you get rid of the source of the infection, remove it and debride it, and then give IV antibiotics. Alright, the reason why you give IV antibiotics last is you want to culture the source and make sure what's causing this, and then give the antibiotics after to kill what's going on. We can also get a lot of skin infections with Staph aureus. First one is impetigo. So you probably heard of this one, and it's seen in young children. It affects usually the face and the extremities. Alright? And this will start out as an erythematous macule, so you have a red spot. It forms into a pustule, which is an elevated pus-filled vesicle. Vesicle means filled with fluid. So it's a vesicle, instead of filled with fluid, it's filled with pus. And the pustules rupture, leading to a honey-crusted lesion. So you have this honey-colored, crusting, like thick lesion on the skin. And if you want to culture, you can actually lift up the lesion and culture what's underneath it. And treatment depends on the cause and the severity. So if it's caused by Staph aureus, it's very mild, not causing systemic symptoms, you just give topical mupirocin, a topical antibiotic, to solve the problem. If there's a lot of lesions and it's caused by Staph aureus, it's more diffuse. So you want to give an oral antibiotic that has higher bioavailability. So you can give oral dicloxacillin or cephalexin. Dicloxacillin is a very classic antibiotic given for methicillin-sensitive Staph aureus because it's resistant to beta-lactamase, and cephalexin is a cephalosporin first generation that's also very good for staph and strep. So these are the antibiotics you can use for Staph aureus. If you have Streptococcus pyogenes causing the impetigo, remember, Strep pyogenes is sensitive to penicillin, while Staph aureus isn't. So if you know the diagnosis of Strep pyogenes, you can give oral penicillin. Next, you can get folliculitis. A follicle is a hair follicle. So you get inflammation and pus accumulation inside or underneath the hair follicle. It gets raised and erythematous. Alright, and it can also be painful. And you've heard of this thing called a stye. A stye or a hordeolum is going to be actually a folliculitis of the eyelid. So very close to the end of the eyelid, near the eyelashes, if you get a follicle being inflamed or if it's inflamed or full of pus, it will cause folliculitis of the eyelid. And how do you treat it? So the treatment, if it's very mild and there's very few pustules present or just a single pustule, you don't need to give antibiotics. They usually go away with warm compresses. So that's a very key association. If you have a lot of pustules, however, you're going to need some kind of topical medication to solve this problem. And topical mupirocin or clindamycin can help. Remember, clindamycin is very good for community-acquired skin infections caused by MRSA. If it's very severe disease and it's resistant to the topical treatment, then you can give an oral, highly bioavailable antibiotic, which we've talked about before. If you're suspicious of MRSA, then you have to give a oral anti-MRSA antibiotic. And these 3 classic antibiotics that can be given, this is very important, you need to memorize this, is oral clindamycin, oral doxycycline, or oral Bactrim. These are very good medications that can be used for cutaneous MRSA, for community-acquired MRSA. So now we have some more diseases to talk about. We have some skin infections that are continued. So we've talked about a few skin infections in the past. We have some more to go over. So the next one is called a furuncle, and that's a boil. Yeah, it sounds terrible, doesn't it? It's this giant lesion that forms, it's nodular. And you can also have a carbuncle, which is even bigger than a furuncle, and that's a coalescence of a bunch of furuncles. So these are some pretty bad abscesses forming caused by Staphylococcus. They're large, painful nodules full of pus and necrotic tissue. So painful nodules full of pus and tissue, and they may have draining sinus tracts, meaning that pus can leak out from the actual nodule to the surface. Carbuncles, however, since they're full of multiple furuncles, they can be more commonly associated with systemic symptoms like fevers and chills and bacteremia. Bacteremia meaning that the Staphylococcus aureus went from the skin and into the blood and caused fever, chills, and other findings by releasing cytokines, or triggering the release of cytokines from our immune systems. So treatment. Obviously, we need to drain and culture it because these large boils, we can't just keep them there. So we have a drainage and culture as our first line treatment. The culture will help us identify what's causing this. And oral antibiotics, since these infections are so large, we need to assume that MRSA is there. We're going to treat empirically. So we want to give antibiotics with MRSA coverage. And if it's got systemic symptoms, such as fever, chills, we want to give vancomycin because we want to protect against the bacteremia. So give IV antibiotics if you have systemic symptoms like fever, chills, hypotension, tachycardia. So how do you prevent this from recurring? So this is a very important thing, obviously. If someone has a boil, we want them to make sure they don't come back with one. And the way you do that is good hygiene. Washing with chlorhexidine soap or isopropyl alcohol, washing those areas, you can prevent Staphylococcus aureus from coming back. And also, you can check the nares for Staphylococcus as well. And if you see MRSA or staph inside the nares, you can treat with topical mupirocin to get rid of it. So now let's talk about bacteremia and endocarditis. So now we're getting to the severe conditions. So Staph aureus can cause a pretty severe endocarditis bacteremia. So this is very high risk in patients who are post-op and using intravascular catheters because these are ways that bacteria can enter the system. When you do an operation, you've opened up the body and now bacteria that normally don't get access to these restricted areas now have access. So it's high risk post-op, and also in catheters because a catheter is inside of a vessel and a bacteria can slip inside of that vessel. So a common site of bacterial dissemination is the endocardium of the heart. So Staph aureus can reach the endocardium, and this is what can cause major problems. And the bacteremia can also be from other Staph aureus related infections as well. So the infection we've just talked about, if you get a bacteremia from it, you could eventually get an endocarditis. So the classic USMLE presentation, the main thing you want to remember is it happens acutely. If you see an acute endocarditis, you should definitely think of Staph aureus because it happens over a few days. Most other forms of endocarditis take a few weeks to months. So you get a sudden onset of fever, a new heart murmur, which you'll hear on auscultation, chills, and fatigue after the bacteremia. All right, what's an easy way to differentiate between causes of endocarditis? Remember, Staph aureus is acute, while most other forms are subacute, such as the strep viridans endocarditis, the enterococcus endocarditis, the Hay-Sec endocarditis. All of these are more subacute and happen in weeks to months. The key thing about Staph aureus is it happens in days. That's a nice way you can remember Staph aureus causing endocarditis. And it's usually going to be a lot more severe and a native valve endocarditis. So Staph aureus is so virulent and binds to the heart valve so well and so tightly that it doesn't even matter if you have a native valve, which means a non-prosthetic valve. The Staph aureus can still attack the native valves. You can also get symptoms associated with the native valve endocarditis due to septic emboli. So endocarditis means that the bacteria are living on the valve and growing and forming colonies. So little bits of colonies can break off. And say you have a septic emboli go into the lung. Say the native valve that's affected is on the right side of the heart. If you have a septic embolus, it will go get stuck in the lung and cause pulmonary nodules and even possibly pneumonias. And if it's on the left side, say the Staph aureus infects the left side of the heart, then it can cause systemic findings like stroke or renal failure or other causes. So left heart septic emboli can cause systemic symptoms, like we mentioned, stroke, renal failure. It can even cause GI problems. The septic emboli can lodge in any vessel. And if it's right heart, it can cause pulmonary symptoms, especially in IV drug users. Remember, IV drug abusers are injecting into their veins. So if Staph aureus gets into the vein, where is it going to go first? The right heart, and it can cause an endocarditis of the right heart. So how do you diagnose this? You diagnose with multiple blood cultures. Because remember, these are very difficult to differentiate between other organisms. You could accidentally get a Staph epidermidis or some contaminator getting into the blood culture. So you need to diagnose with multiple blood cultures and see multiple Staph aureus positive, multiple Staph aureus positive blood cultures. So only if you have multiple Staph aureus positive blood cultures can you definitively say this bacteremia/endocarditis was caused by Staph aureus. And now the best test for bacteremia endocarditis, or endocarditis caused by bacteremia, is an echocardiogram. That'll show you the actual vegetation that's living on the heart valve. So treatment, you need to empirically treat with vancomycin because it's acute endocarditis. You know it's probably caused by Staph aureus, so you empirically treat with vancomycin while they're in the hospital. And then for home, if you culture it and find out it's methicillin-sensitive Staph aureus, you can give IV oxacillin or cefazolin. You can give one of the milder antibiotics that just treat regular Staph aureus for 6 weeks. But if it's known to be MRSA, you need to give the big guns like vancomycin, and that needs to be given for 6 weeks.